Hello, good morning. My name is Steven Aguilar. Presentation is my topic is COVID-19 versus evolution in advanced renal cell carcinoma. Continue. Definition: Carboxin is an oral small molecule tyrosine kinase inhibitor that targets vascular endothelial growth factor receptor, as well as MET and which has been implanted in the pathobiology of metastatic renal cell carcinoma or in the development of resistance to antiangiogenic drugs. This randomized open-label phase 3 trial evaluated the efficacy of cabozantinib as compared with everolimus in patients with renal cell carcinoma that had progressed after VEGFR targeted therapy. Continue video.
Meteor is a randomized phase 3 trial, global international trial that randomized patients to standard everolimus and accepted second or later line standard in metastatic clear cell RCC after progression on first line treatment with an anti-angiogenic agent. So patients were randomized to everolimus as standard dose, 10 milligram once a day orally, or to the experimental agent cabozantinib at 60 milligram once a day. Cabozantinib is a multi-tyrosine kinase inhibitor that offers inhibition of the VEGF receptor in addition to other multiple pathways involved in VEGF resistance, so delaying this VEGF receptor resistance, such as MET and XL. One-to-one randomization between cabozantinib and everolimus. The study actually primary endpoint of progression-free survival was met, and the results were published in the New England Journal of Medicine last year and presented at the European Congress. Now at ASCO 2016, we're presenting key secondary endpoint of overall survival. This was also met, resulting in almost 5 months difference in survival between the control arm, everolimus, and the cabozantinib experimental arm. Superiority in terms of overall survival as well as progression-free survival and response rate for cabozantinib.
Okay, continue. Application in medicine. Progress-free survival was longer with cabozantinib than with everolimus in his randomized phase 3 trial involving patients with renal cell carcinoma that had previously progressed during at least one year VEGFR targeted therapy. The efficacy with cabozantinib was robust with an estimated median progress-free survival of 7.4 months as compared with 3.8 months with everolimus and a hazard ratio of 0.68 corresponding to a 42% reduction in the rate of disease progression or death. Objective tumor responses were observed in 21% of the patients assigned to cabozantinib as compared with 5% of the patients assigned to everolimus. Continue. Pros and cons. Pros: the efficacy and clinical safety of cabozantinib have always been correct in the indication. Accuracy be a phase 3 clinical trial, open, randomized, and controlled with everolimus method. Compared then in the patients with advanced clear cell renal carcinoma whose disease had progressed during or after a previous treatment with active tyrosine inhibitors on VEGFR. Cons: it doesn't have a continuous video.
We have conducted a phase 3 trial looking at a novel agent called cabozantinib, which is a dual VEGF receptor MET and XL inhibitor in a population of patients that progress on prior VEGF inhibitors. The control arm was everolimus in this trial, which is a drug approved many years ago and been a standard in advanced RCC patients, second line and later. And the choice for cabozantinib is based on the fact that it does block the VEGF receptor as a backbone, but also block multiple other tyrosine kinases involved in mechanism of resistance, acquired resistance to VEGF inhibitors such as MET and XL. And the study in terms of primary endpoint was met, showing a hazard ratio of 0.58 and a significant decrease and significant increase in the progression-free survival with cabozantinib compared to everolimus. This was already published in 2015 in the New England Journal of Medicine and presented at ESMO. What we did here with the new research that followed is we updated overall survival. These are the final results for overall survival. Overall survival was a secondary, not a primary endpoint on METEOR trial, but it was powered, and it was a very important secondary endpoint, a gold standard in oncology, if you may think about it, overall survival. And actually, overall survival was met with almost 5 months prolongation with cabozantinib over everolimus in survival. Response rate also were updated in the presentation and favored largely cabozantinib. So we have a drug that actually prolong overall survival and also shows superior progression-free survival and response rate over a previously considered the standard drug in everolimus. What I would add is that the safety profile overall was not different from other TKIs we're used to, although the dose reduction.
Video. Continue.
We have several studies we presented, interesting studies. So I'll start with a study going to be presented in the residential session on Monday afternoon. A study of frontline cabozantinib versus sunitinib in previously untreated patients of IMDC intermediate and poor risk categories. So the hypothesis was that cabozantinib, which is a VEGF, MET, and XL inhibitor, could provide superior efficacy to a VEGF receptor inhibitor standard that has been for many years sunitinib. And in fact, the study met its primary endpoint, and the result for the first time you will be seeing here at the ESMO meeting. So cabozantinib provided superior progression-free survival as well as response rate over sunitinib with a similar adverse event profile. So this could be practice-changing. And the second study I'm going to talk about is a combination study in patients that are also previously untreated, but it's a preliminary phase 1 study combining axitinib, which is a VEGF receptor inhibitor, with pembrolizumab, which is
Continue.
Sandy, it would be easy for us if this was the end of the story, but it's not the end of the story. And there's 2 additional pieces of information that are just around the corner that are going to complicate this even further. So let's spend some time talking about some as yet unapproved but recently studied and presented data on both the role of lenvatinib and the role of cabozantinib. So let's first talk about lenvatinib. So Bob Motzer reported at ASCO a randomized trial comparing a combination of lenvatinib and everolimus compared with a control. And it was a randomized trial, and the results were striking. Striking so much that maybe the FDA will consider that sufficient information for their approval. That's in their domain. But tell us a little bit about this drug called lenvatinib, what it does, why it might be doing something differently than other VEGF receptor TKIs, and should we maybe keep our minds open about combination therapy in the second-line setting?
Exactly. I mean, I think we spoke about combinations before, but this might be opening combination therapy story all over again. So lenvatinib targets VEGF, but it also targets FGF, and that's always been thought as a mechanism of resistance. So this was a 3-arm trial, and they looked at lenvatinib as a single agent, compared it to everolimus single agent, but also used a lower dose of both lenvatinib and everolimus. And what really surprised me was that the PFS for the combination was almost double that of single agent lenvatinib. And the PFS for everolimus was similar to what we have seen in its original approval. So I think that the patient population is real. So seeing everolimus with a PFS of around 5 makes you think that that's real. But the combination resulted in a PFS of almost 14 months, which was really astonishing. I think it is real, and the side effect profile was not that different from what you expect for a VEGF and mTOR. But I mean, it's hard to get too excited about combinations. I don't know if people would go back to it. Would you get the same if you were to do it sequentially? And I don't know how people would feel about taking 2 drugs. Both are oral, unlike the other combinations that we've spoken about in the past.
So we have a 13 or 14 month PFS in the second line setting, which is far superior to any other agent that's been used in that setting. And these are, let's talk about cabozantinib and the METEOR study, because here we have an agent that is different. I'd like you to describe what it does and some of the results of that New England Journal article. And then maybe as a group, we can then have a conversation. Imagine that these agents might be commercially available for us sometime in the future. How are we going to navigate through these decision making?
Sure. I think, cabozantinib is interesting because it blocks, in addition to the VEGF receptors, as we mentioned, c-Met and AXL. And we published a paper from our group in Oncogene a few months ago looking at to support this clinical trial. Although the trial, the METEOR, was designed and launched and conducted before the results of our preclinical work, but our preclinical work suggested patients, tumors that are treated with sunitinib do have an escape with mTOR, with AXL and c-Met, and bring in a drug that blocks this does actually produce tumor growth inhibition. So I think now we are finally, we believe that the c-Met and the AXL pathways are pathways that are relevant in progression, certainly after VEGF exposure. So the METEOR trial was a large trial, phase 3 trial, looking at 658 patients randomized between cabozantinib and everolimus, the primary endpoint, progression-free survival, and it came astonishingly 7.4 months median PFS with cabozantinib compared to 3.8 months median PFS with everolimus. And there was a trend for the secondary endpoint, OS, also in favor of cabozantinib. So I think this drug I anticipate it to be approved pretty soon, and it will be another, so will be number 10 for us in our armamentarium to have for our patients. So, but
Thank you. In conclusion, progressing free survival was longer with cabozantinib than with everolimus among patients with renal cell carcinoma that had progressed after VEGFR targeted therapy. Thank you.